Now request Dr. SARATH Ravi to give his talk on coexisting macular disorders with cataract.
Thank you, Harshali, for this opportunity. I'll be dealing with how to optimize the results of cataract surgery when you have a coexisting macular pathology. In this discussion, we'll be going through some of the common macular pathologies that we encounter in patients who turn up for cataract surgery. And one of the most common is an epiretinal membrane. So epiretinal membranes are semi-transparent vascular fibrocellular membranes which have a contractile property, and their prevalence is usually increasing with age. Therefore, patients with cataract and epiretinal membrane can coexist. So which are the epiretinal membranes that you have to intervene? It depends upon those which could be symptomatic. It depends upon the thickness of the membrane, the amount of retinal distortion, the amount of vitreomacular traction, and the amount of retinal edema. I mean, usually these patients might complain of micropsia, metamorphopsia, or binocular interference, or a monocular diplopia. So this is a very early epiretinal membrane with a mild sheen or a irregular reflex without a distinct edge, and usually there is no obscuration of the underlying blood vessels, and there is no retinal distortion. Whereas in a crinkled cellophane maculopathy, you have a wrinkling of the inner retina, and also you have the retinal vessels appearing tortuous, and vessels seem to be pulled towards an epicenter. Whereas macular puckers are opaque membranes, and these definitely require intervention, and these opaque membranes can cause prominent retinal distortion resulting in foveal ectopia, and the underlying retinal vessels are not visible. And OCT helps in the assessment of these patients with epiretinal membrane because it's seen as a hyperreflective band. You can see the amount of adherence to the underlying retina, which could be a globally adherent membrane or it could be focally adherent. Also, you can visualize the amount of retinal thickness, differentiate between a true hole and a pseudo hole. And this is a stage of the epiretinal membrane Daviston OCT. Stage 1 where you have the foveal pit being present. Stage 2 where the foveal pit is absent and the layers are distinct. And in stage 3 you have an additional ectopic inner foveal layer. And in stage 4 you have the layers getting disrupted. So there are a lot of prognostic signs in epiretinal membrane on OCT, where you see a hyperreflective zone at the fovea between the ellipsoid zone and the cost line, and this is referred to as the cotton ball sign. And this can over a period of time progress to form acquired vitelliform lesions, which are indicative of a poor prognosis. The other poor prognostic signs include an ectopic inner foveal layer or an inner retinal irregularity, presence of cystoid edema, loss of ellipsoid zone, and also an increased central foveal thickness. So following a co-vitrectomy and PVD induction, you stain the ILM with the BBG dye and you start peeling the ILM towards the macula. The ERM creates something like a negative staining, and you pick up the epiretinal membrane towards the macula, and repeated staining with the dye can help in a more complete removal of the ILM as well as the epiretinal membrane. This is another patient with coexisting cataract and epiretinal membrane with a prominent distortion of the macula. You start with a double membrane peel, that is ILM peeling from the end of the arcade, peel towards the macula, and start peeling the epiretinal membrane and complete the peeling of the ILM. Usually a double membrane peel ensures a more complete removal of the epiretinal membrane and reduce recurrence rate. This video is only the peeling of the epiretinal membrane. However, in terms of the two procedures, there is not much difference, visually significant difference in terms of the final visual acuity. This is a patient with coexisting cataract with epiretinal membrane and a prominent spongy edema of the retina who underwent a combined phaco-vitrectomy along with a double membrane peel and SF6 tamponade. At 2 months, you have good resolution of the macular edema with the restoration of the foveal depth and also the good functional improvement. And this is another patient with cataract and epiretinal membrane who underwent a combined surgery with double membrane peel, and post-operatively there was good anatomical and functional improvement. The other thing that you encounter in cataract patients is an interface abnormality. A vitreomacular adhesion and traction are usually two entities of a spectrum during the course of an incomplete PVD. An adhesion usually is characterized by a partial PVD and persistent attachment of the vitreous to the central 3 millimeters and an acute angle between the posterior hyaloid and the inner retinal surface. And however, there is no change in the foveal contour. Whereas in vitreomacular traction, you have the foveal contour being altered either because of a distortion of foveal surface or elevation of the fovea from the RPE, or intraretinal structural changes like a pseudocyst. And based on the width of attachment, you can classify it as either a focal attachment less than 1500 micron attachment, or a broad one where it's more than 1500. And etiology wise, it could be an isolated pathology, or it could be associated with a concurrent whether a new wet AMD or RV or diabetic macular edema. Whereas full thickness holes could also be present along with cataract. These appear as full thickness interruption in retinal layers due to an anteroposterior or a tangential traction. And these are graded according to the gaseous staging or the International VMT classification based on size of hole and the presence or absence of VMT. Following a co-vitrectomy and PVD induction, the ILM is stained with BBG dye, and the ILM is peeled in multiple flaps. You start peeling from the end of the arcade and raise multiple flaps towards the edge of the fovea or the edge of the full thickness hole. You don't completely strip off the ILM from the retinal surface. You leave the flaps adherent to the edge of the fovea. And this is followed by gas tamponade. And normally in cases of traction, vitreomacular traction, you use SF6 tamponade or air, whereas in cases of macular hole, you use a C3F8 tamponade. And this patient with a coexisting cataract with VMT and tractional crisis underwent a combined phaco-vitrectomy with ILM peel and SF6 tamponade. At 1 month post-operatively, there was good anatomical and functional improvement, vision improving to 6, 9 and 6. And this patient who came up for cataract surgery in a left eye on a routine pre-op OCT was detected to have vitreomacular traction, underwent combined surgery with ILM peel and SF6 tamponade. At 1 week post-operatively, you have the gas fill around 50%, and you see the ILM flaps still being adherent to the edge of the fovea. And this patient with a broad VMT and epiretinal membrane and cataract underwent combined phaco-vitrectomy with double membrane peel and SF6 tamponade, had good anatomical and functional result at the end of 2 months. And this patient with full thickness macular hole and cataract underwent phaco-vitrectomy with an inverted flap of ILM peel and C3F8 tamponade. At 2 months, there was a type 1 closure of the full thickness hole with a good functional improvement. And because of the gas tamponade, sometimes there could be a forward shift of the IOL, as well as there could be an optic capture, posterior synechia, as well as decentration of IOLs. These are most common with single piece IOL than with a 3-piece IOL. Regarding IOL selection, the subsequent speaker will talk on it. And this is a patient with pre-existing cataract with macular edema due to a retinal vein occlusion. Patient underwent, we did a combined IOL with the anti-VEGF injection being given at the end of the procedure. At 1 month, you have good resolution of the macular edema and a clear media. But these patients need to be counseled that this is not a one-step procedure. They might require a frequent follow-up so as to pick up any rebound edema. And some of your cataract surgery patients may have such a pathology in the macula where you find cavitations in the inner or the outer retina, or a foveal loss of ellipsoid zone and thinning of the fovea. And these patients with the foveal loss of ellipsoid zone have a final post-op visual acuity less than 612, and these are the patients who have a early loss of vision following the surgery also because of disease progression, rather than the cataract got to do anything with the progression. So therefore, it's important to understand that it's possible to give good results in macular pathologies, and macular pathology per se should not be a deterrent to advise cataract. And with a proper instrumentation and a good skill set, probably you can give a good functional and anatomical result by a combined approach. But patients need to be counseled so that they have realistic expectations regarding the vision and also regarding post-op care, which includes posturing, which might be crucial in these cases. Thank you.
Thanks, Sharath. Nice talk. So most of the cases you seem to be doing a combined approach for
Yes,
coexistent disorders. Are there any situations where you would prefer a phased, stepwise intervention?
So in our setup, we mostly do a combined procedure, but as you see, there could be all this IOL shift and also the optic capture happening. But when you do a sequential surgery, like first you do the cataract and 2 weeks later you take up for the macular surgery, then usually these complications are less common. But the patient has to go through the trouble of going through a second surgery or a second procedure. That is why we usually take up for a combined surgery. And most of these IOL complications occur in patients who don't lie prone with the gas in situ, and they have a forward shift of IOL or a pupil block happening post-operatively.
In a VMD case, can we just do away with the tamponade?
Yeah, we could just do air fill. I usually prefer a tamponade, at least air. I fill in with the fluid air exchange at the end of the procedure rather than a saline fill.